Hi, everybody. It's Karen Anderson with Aortic Hope, and I am here with Dr. Stacy Fisher, and we're going to hang out for just a couple of minutes as people start to join in, since I did say 5 o'clock, and it's only 4:59. So I'm a little ahead of the game here. And I guess until then, I'm just going to bring you guys up to speed with some things going on right now with Aortic Hope. As you know, we are in the 31 days of joy and hope online, and it is so much fun. And I have to tell you, I love reading. Hey, Tia, I love reading everybody's responses. It's so great, even if you're just having a bad day, to read something awesome that someone else posts about a smell that brings them joy, or a food, or a sound. It's been a lot of fun. So thanks so much for joining in. Elfster ends on Saturday. So if you have not sent your present out yet or received one, that's okay. Let's give it a couple days. But by next Wednesday, if you participated, please shoot me a message and I'll double check to see where we are in the process. And what else we have? This is a great time for everybody to go on the Hope Shop and purchase your last minute Christmas items. I will tell you personally, I love the PJs. They're really, really nice and toasty warm. We have a shop with some merchandise, and I just purchased some red flannel long bottoms and a short sleeve top with Aortic Hope, and it's so cute. And it's so comfy, and I really love it. So you guys should buy some pajamas too. I don't know. You buy anything
through the Facebook site?
That's through a site called cafepress.com /Hope Shop. And we have all kinds of really great merchandise on there. One of our administrators, Tia, has been diligently working to put our logo on anything that can have a logo, from an ornament to pants to shirts to cups, you name it. We've got so much stuff on there, and it's it's a lot of fun. Great last minute holiday items. So yeah. All right, we've got a couple people, and I know Dr. Fisher's time is very precious to us all, so we're going to just kind of get started. And we've done this series before. It was actually almost a year ago that we did this.
Almost exactly.
Yeah, almost exactly. And the fortunate / unfortunate part is that there are more people now part of our page. Fortunate because we love having you here, and that means you have survived and you're here. And unfortunate, of course, because that means that you've suffered something related to aortic disease. So this is a good opportunity for you guys to, look, someone's posted our link for Cafe Press. That's great. Perfect. There we go. So this is a great time for you guys to start thinking about topics or questions you might have for Dr. Fisher. She's just going to, why don't we start with you telling everybody here a little bit about yourself, your background, and then we'll just start talking about the importance of a cardiologist after having any type of aortic event.
Sure. My name's Stacy Fisher. I am a cardiologist that specializes in cardiogenetic diseases and also adult congenital heart disease. And I take care of specifically a lot of pregnancy-related heart disease, so people that may have aortic disease in pregnancy or cardiac disease in pregnancy, the moms. I became interested in cardiology during my internal medicine residency at Duke, and was fascinated in the adult congenital clinics, met the most wonderful people and amazing situations that could be transformed. I think I'm one of the luckiest practitioners because I have amazing patients like Karen. I also get to see people do well because the technologies work. People do well when they do what they need to do to stay healthy, and when they come for care and recognize symptoms early, and that does make all the difference. So I certainly advocate understanding the illness that you have, excluding illnesses that you don't have. Cardiogenetics can be a huge part of that, with understanding why you may have a weakness in the connective tissue and who in your family is actually predisposed or disposed to having that. So I think family screening for this type of disease is extremely important and goes a long way in preventing sudden death and potentially actually fixing a problem before it becomes a life-threatening problem.
Well, let me ask you a real quick question regarding that. I'm just going to do a little technical, get you more centered here. So putting aside if somebody experienced a dissection via a traumatic event or even from pregnancy, do you recommend that everybody, if you've experienced a dissection or all of a sudden you just grow a really large aneurysm and you or otherwise a healthy person, do you recommend that there is some genetic screening done? Because this I mean, what's the chances it's just a fluke? It just, I'm sure the flukes happen, but there has to be something.
So it's generally not a fluke.
Okay, well, that's good to know.
It's very rare for it to be a sporadic problem.
Mm-hmm.
Usually there has to be a weakness. Now, if there's a trauma, that's different, right? We're all, we're all prone to something like a trauma. If there is severe blockages in the vessels, like calcification or atherosclerotic disease, similar to coronary disease, where some people are more prone to making more plaque, and you can actually tear around a plaque. So if you have plaque disease or you have really, really high blood pressure, like malignant high blood pressure, then those are times where you actually have an explanation. Okay. And you have something to treat, and you have a focused reason that makes sense. There are also people who have 2 leaflets instead of 3 on the aortic valve. That's called a bicuspid aortic valve, and in certain shapes of that, you can be more prone to a weak connective tissue. And that is explained by the bicuspid aortic valve. We don't actually have good genetic testing for that. Mm-hmm. And in that condition, it's about 5% of family members that would be affected. Okay. Outside of those explained causes, if somebody has an aortic aneurysm or tear, including what people that have had it in pregnancy, there's not a good reason why one person has it and one person doesn't without delving a little bit deeper. And if you do find something like a connective tissue problem like Marfan's or Ehlers-Danlos syndrome, there are other issues that can go with those syndromes that some proactive treatment could actually provide a lot of relief, a better understanding of other health issues, and also better family screening.
Okay, so what if you have screening and it turns up nothing yet?
You can. And again, in aortic disease, so you take somebody who has an aortic dissection who doesn't have any features of Marfan's disease or Ehlers-Danlos disease or other types of syndromes. For those patients, it's only about 40 to 60% likely that the genetic testing and the commercially available profiles is going to actually show you what the cause is. And it is a little bit like fishing, where we're testing a standard profile that in general would explain about 60 to 80% of the cases. But if you've already excluded all the things that have, all of the people that have other at least morphologic features of some of the syndromes, then it would be more like 40 to 50% likely. If you do the testing for genetics, there are 3 possibilities. One, that you have a gene that explains it, in which case your family can be tested just for the one spot on that one gene that's abnormal, and people would know if they're a carrier or not of what made you prone to the dissection. Okay. If they're a carrier, they get screening. If they're not, they're home free. Okay. So it helps both people that are tested. Okay. If in fact your genetics come out negative, then we recommend screening depending on your family history. And again, depending on who you are and what happens. So again, if you had a car accident, no family history, you probably shouldn't get the genetics at all. If you had a car accident, a dissection, but you have a strong family history, maybe grandpa died of an aneurysm in the belly, maybe somebody else had a cerebral aneurysm, maybe your aorta was weak and someone else in that car accident wouldn't have had the dissection, maybe we should do better screening. Okay. In that case, you come out negative. We don't really recommend the family screening except for the belly at age 50 or 60, unless the person affected was younger. But if you have something, then we would certainly recommend the family screening. In somebody where it's really not clear why they had a dissection, I would definitely recommend the genetics. If they're negative, then we would recommend screening of first-degree family members, which is brothers, sisters, parents, children. And the first type of screening I would do is the echo. And in some people, we can see a large portion of the aorta on the echo. And in some people, depending on the shape of the chest, the lungs, how much smoking they've done in the past, the health of their lungs, we can't. So we do know what we can see and what we can't see to recommend who might need a CAT scan or MRI and who has actually gotten a good screening. And again, we also look at the part of the aorta that had a problem for their family members.
I think some of the things I've seen online, some of your questions, and I see, hi everybody, seeing you all come up, and we'll try to get to all your questions as soon as we can. But I know that I've heard some questions, and I've had a question personally, is when your results come back and it's not giving you a name or a type of any genetic issue, but it's assumed that there's probably a connective tissue disorder, how long do you wait before you get tested again to see if there's something that's abnormal that is found, because there's really no name and there's nothing definitive.
Well,
but
so if the
something
genetics are negative, you're not going to look for the genetics anymore.
Okay.
And I see somebody, Shirley actually posted that she had giant cell arteritis, or a type of vasculitis. So vasculitis is a whole different scenario. In general, when you have vasculitis, you're actually sick. So most people have fevers, night sweats, pain, or other types of inflammatory reactions, and your inflammatory markers are high. So for example, in temporal arteritis or another type of vasculitis, like the sedimentation rate is high. So those are not genetic problems. Those are things that would be isolated to that person, the vasculitis, and are rarely running in families. Other types of autoimmune problems like Crohn's, like lupus, they are higher in certain family members. And at the same time, most people have symptoms. They have arthritis, or they have discomfort in the muscles and joints. They have abnormal bowel patterns. They have night sweats. They have fevers. They feel bad. They have extreme fatigue. So in those cases, most people are actually sick. Now, when somebody actually has an aortic dissection, the regular testing that should be done should include things that look for vasculitis, and it does look different on things like a CAT scan or MRI. So when we're talking about genetic testing, we're talking about the people that don't have an explanation from things like vasculitis or Lyme disease or trauma or malignant hypertension or atherosclerotic disease.
Okay. So something else I wanted to talk about, just the general nature of why it's important to have a cardiologist. Why is it, I mean, other than obvious, but what is it that maybe we can come to the table as far as questions? I know a lot of people have had questions about medication, so what really would be the primary role and relationship between patient and cardiologist?
So one of the biggest things is ongoing screening. So some people are regularly followed by their surgeon in an aortic disease center. And for example, at University of Maryland, where I am, we have a wonderful aortic disease center where we talk to each other, and we try to spread out the screening so that sometimes you meet with a cardiologist. If your primary problem is hypertension, there's a hypertension specialist, Dr. Johnson. If somebody actually has active issues with the dissection site or concern for continued dissection, often the surgeon will continue to follow that person, and we'll have a big input on the screening schedule. Okay. And also we'll relook as we get further scans and have a very big input into their care. But the role of the cardiologist is ongoing screening, management of blood pressure, management of secondary risk factors like cholesterol, and working with the primary care doctor or rheumatologist or geneticist about managing comorbid issues. So the cardiologist wouldn't be treating something like the arthritis, but they could at least bring up, well, we're seeing changes in the vasculature, the disease may be active. Okay. Or in some of the problems like lupus, we may see changes in the pulmonary pressure on echo. And we recommend an echo or ultrasound of the heart every so often just to estimate the pulmonary pressure, because certain conditions are related to elevations in the pulmonary pressure. And it's important to find those if they're happening. So the role of the cardiologist is that. Okay. I'm going to take another question here. I do see, Tia, you sent me something from Mike. Can you type that on here, because I can't get to my phone to see that. But Betsy says, I'm adopted and my birth mom and all women on my mom's side have heart issues, but not dissection except for her. Should she have her children tested? Yeah, so if she had an aortic dissection and it's not clear why, and again, if there was a clear reason, then the kids don't need to be tested. If there's not a clear reason, the kids need to be tested, but she should be tested first. Okay. So, for example, Betsy's genetics should be done. If they're negative, the kids can be screened with echo. If they're and then get put on a schedule of when they should get their next one based on their own dimensions. And again, if their dimensions are a little bit large, they should get screened earlier. Mm-hmm. Where if they're stone cold normal, they would be screened at different intervals depending on their ages and their growth rate. So if they're in a growth spurt, they're at more risk to develop an aneurysm during that time. Oh. They'd get screened a little bit closer. Okay. So we would look at things like puberty, growth rate, and mm-hmm. their actual sizes indexed for their age and body size. Okay.
Then we've got John, dissected at 43. His brothers, who are younger than him but are twins, are being screened. Surgeon told him that they should be tested. So
yeah, they should, and also John's brothers and parents should be screened. So we recommend first-degree family members, and then brothers, sisters, and parents. I didn't mean to put sister out if you have one, John.
So for me, I had nothing, came back on my genetics, but I have Crohn's, and my mother and everybody on my mother's side, I would say 95% of them all have Crohn's or colitis, and my father has an abdominal aneurysm. So I was tested, nothing came back genetics, but I had my son, had his retinas checked because I've detached those too, and he had an echo and everything. Now his baselines have been covered as normal, and then I guess they'll remind me and tell me when I have to bring them back because I can't remember right now.
And also while they're being tested, the kids, mm-hmm. It's really important to look at their risk factors. So for example, if you're seeing a cardiologist for the testing, they should actually look at their cholesterol, their blood pressure, their blood mm-hmm. sugar, their weight, their exercise pattern, their diet. So it's an opportunity to say, well, hey, you may be a little bit more prone. Let's take away the secondary risks. Mm-hmm. Let's try to get those in order. Let's protect you from other aspects. And then hopefully you get more out of that.
Well, my 18-year-old just finished his first semester at college where he packed on 10 pounds. So if he's watching, you do have your doctor's appointment on your winter break. Just letting you know, we're gonna do a baseline test for all those goodies that Dr. Fisher just mentioned. So Betsy said, what are your recommendations for her kids? So again, she did dissect, and her all women on her mother's side from her birth mom had heart issues. So she wants to know if her children should be tested.
Yeah, they should definitely be tested. And again, Betsy should have the genetics first. Right. And we talked about 2 of the 3 possibilities with the genetics. One is that they're abnormal and the kids can just get tested for that spot with a cheek swab or a blood test, either one. Okay. And it's very expensive for the incident person. Generally can get covered through insurances. But it's very inexpensive for the one spot on the one gene. So especially if you have a large family, it becomes very cost effective to do it that way. And again, it's also very valuable if you're the one that screens out, you're mm-hmm. home free, right? Yeah. There's also the possibility of negative, which we talked about, and then there's the possibility of something called a variant of unknown significance. And that's the most annoying and hardest possibility. Mm-hmm. And we really treat that as negative. Because you wouldn't want to test someone else for a variant. Now, if in your family you have more than one person affected with aortic disease, you can test the other person with, say, an aneurysm and see if that variant tracks in your family. And generally, the gene companies will do that for free to try to figure out, does this variant matter in your family and for other families? And that's how the understanding of these variants builds. Okay. But if it's a variant, we kind of put it in the pocket. We look at it over time and we see how it's screening out for other families. So that's something you would want to come back to a couple years later and relook and say, well, what is the literature ended up showing about my variant? And maybe it becomes significant, and maybe it's just part of your natural fingerprint and just the
just an is.
It's just an is, and it doesn't have anything to do with it. Okay. So for those people, we treat them as negative and screen the kids with echo or CT or MRI, again, depending on the site mm-hmm. of the aneurysm. For brain scanning, we usually only do that in Marfan's patients, vascular Ehlers-Danlos, not the hypermobile Ehlers-Danlos, or people with a family history of brain aneurysm.
Okay. Betsy, if you have any other questions, let us know. Two more questions before then I go back and ask one. So the question I think was from Mike. So it says, I was adopted. Oh no, I'm not too sure if it's from Mike, but let me see. It says, I was adopted at birth. And the one piece of health information I have is that my biological father had a heart murmur. This person watched the Ellen show with John Dornbros and was floored when he said his aortic aneurysm was diagnosed from a heart murmur and a subsequent CT scan. Is this an indication my condition is genetic? And should I be tested and try to contact my biological parents to warn my siblings? They were all very young when I was born, so it seems likely that I would be the eldest of any siblings. I'll let you read that one again.
So John had a dissection?
No, so he had an aneurysm. It was very big. This guy that was on Ellen.
Okay, and
it was like
but this patient.
This patient has a father with a heart murmur. So John had mentioned that his aneurysm was detected because he had a heart murmur. So when they went in to do a
That's
CT,
the person on the Ellen show.
Yes,
but the person writing the question
does not say,
have an aneurysm or dissection.
No, does not seem so.
Right. So a heart murmur is like a car noise. It's kind of a basket diagnosis. It just means there's noise.
Okay.
There are a lot of specifics about the heart murmur, and about some of them are completely benign. Some of them are very, very important. Okay. We have found aneurysms with heart murmurs, but generally it's an aortic murmur. Often it's an aortic insufficiency murmur where the valve is leaky because it's stretched.
Okay.
So if it's that type of murmur, then you're certainly going to look for an aneurysm. If it's a murmur of a bicuspid aortic valve, which again is in 5% of patients, then that would certainly be something of concern. But the heart murmur is very common and could be from any of the four valves. So flow murmur, anemia can give you a murmur, pregnancy can give you a murmur. So again, a murmur isn't something that's always bad.
So you don't have to necessarily go run for the CT.
So if your parent had a murmur, you don't have to get checked unless you have a murmur.
Okay.
But that's not an indication that you have aortic disease.
Okay. Next question. Jean, both my mother and brother did not survive an aortic dissection. Should our family have genetic testing? We were told that genetic testing would not take place until a family member was diagnosed with an enlarged aorta. I'm not sure if you had a dissection yourself, you don't specify, but if I just assume that maybe you did.
No, it sounds like this person didn't.
Just your mother and brother did not survive.
So unfortunately, no genetics were taken on the mother and brother.
Okay. So
genetic testing on an individual family member is going to be fishing. And if it comes out negative, we don't know if we're actually testing for something that the mother and brother had, or if we're giving false assurance.
Okay.
So what they should have is they should actually have a really good exam, and often a good exam by either a cardiogenetics person or a genetics MD, where they're really looking for some of the facial features for Loeys-Dietz syndrome, for Marfan's, for Ehlers-Danlos, where they actually check some of the morphologic things. And then again, I would put all of the first degree relatives on a screening protocol. So for each, the mother and the brother, I believe it was, but for each person that had a dissection, their parents, brothers, sisters, children that are living should have screening. And that screening, depending on if we know where the dissection was, should include the area that was dissected.
Okay.
So if they were both ascending aorta, you would either an echo or a CT or MRI. And if you can't see one way, you would do a different modality. And then probably about every 5 years for that family. That's a striking family history. And again, the likelihood that the genetic testing would be positive is very high, but only in the 50% of people that have it.
Okay.
So if somebody does start developing an aneurysm, you definitely want to grab the genetics on that person. And again, increase the screening group that you're doing.
So I have a question. We haven't gotten it yet on here, but especially for a lot of the newer people who have joined our groups, and it still comes up in conversation. A lot of us talk about our blood pressure, and I think that when we're new to having this experience, whether it's aneurysm or dissection, we see anything that goes over 120. Or even 120 or over 70 something, like, when do you go to the hospital? When is it just a spike? And what what is really the time frame? You know, how long do you let that spike go? A lot of us really worry about that, and I don't think we're told enough information on the front end, and even if we are, I don't think we retain it, and
so
it's just
I think
emotional.
that's a really, really important and thoughtful question, and we do recommend home blood pressure screening for anybody who's had a dissection. And the tight blood pressure control is important, but you still need to have a natural range.
Mm-hmm.
So if the blood pressure is really flat, you don't want that. You'll feel terrible. The blood pressure should have a natural range. It should go up when you're under stress, happy or sad. It should go up during exercise and then come back down below where it started. That would be a healthy response to blood pressure. And the range during exercise, for example, if your blood pressure is 120/80, and you're exercising pretty hard, it can go up to 180 or so. But you don't want it to go up to 200, right? So you want the range controlled, and you want your average resting blood pressure, a time when you just kind of average time. You know, you get up, you're having a normal day. No day is perfectly normal, but your kind of usual day. Mm-hmm. Those are the times to check it. And what you want to do is keep a log and keep an average. So if you're getting numbers that with the bottom number, say above 95, you're going to want to check with your doctor immediately. If you're getting numbers, you know, with the bottom number above 100 and you've had aortic dissection, that's where, again, call your doctor but have a low threshold to go to the hospital if it doesn't come down. You can give it about 20 minutes. You can drink a lot of water. You can take your medicines if you haven't taken them. You can lay down and rest, you can meditate, you can do things to try to bring the blood pressure down. But if it's not coming down, then you really do need to take care of that. And again, what you really want to do is keep a log of what your range is. Mm-hmm. Bring that log with you to your doctor. You never want to treat every number. And the tendency, especially in some cultures, is to treat every single number. And all you do with that is get into really bad trouble, because a lot of the blood pressure medicines actually have their impact 6, 8, 10 hours later, depending on which medicine.
Right.
So some of what we do with blood pressure control is timing the medicines to cover the times where you're having trouble. So keeping that log, time, date, pressure, and bringing it into your doctor will allow not only picking the right medicines with the right times that they get good coverage, but also timing them. So you may take some of them at night, or you may take them in the morning. Or you may need a midday dose, but you can actually get a much better 24-hour coverage by looking at when you spike and what your numbers are.
And now that's very interesting, because I didn't realize that until we spoke. I just assumed with blood pressure medicine, just like a Tylenol, it's going to work within 20 minutes to a half hour. And you just made a very big point. And I do not think a lot of people out here realize that a lot of our medications can take 2 to 4 hours before they actually take effect. They're not instant in helping necessarily to bring down your pressure.
Right, and some medicines like amlodipine is a common blood pressure medicine used in aortic disease. That can actually take 2 to 4 weeks to have its peak effect.
Yeah.
And it can take a week or two to be completely out of the system. So as you're getting on and off it, you know, you're going to see some fluctuations, and you're going to see it kind of come down as you get on it and kind of come up as you get off of it.
It's like chemistry. It's what it sounds like with the medications.
Exactly like chemistry, but they do have, you know, published half-lives, time to peak onset, and the goal of most of these medicines is to give you 24-hour coverage. Some of the medicines, however, are not 24 hours. For example, labetalol is a common one. So labetalol is meant to be a 2 to 3 time per day medicine. Otherwise, you're going to get big peaks and valleys in your coverage.
And speaking of labetalol, and I'm going to get to your questions in a minute. I'm seeing they're all starting to come in. I've heard some positive things from people on the site, and I've also heard a lot of negatives. I mean, there are people that take way above 900 milligrams, which is what I started off on labetalol, and a lot of people complain that they almost feel like a zombie, and there's just a lot of bizarre side effects of some of the drugs. And I think the importance is there's many different types of drugs, that if you're not feeling good on that drug, you can talk to your doctor and work towards a different type of medication.
Right. But during pregnancy, for example, there are only certain ones that are actually safe for everybody.
Okay.
If somebody has other medical problems, many of the blood pressure pills have very nice side effects. For example, the ACE inhibitors can help protect the kidneys and diabetes, even help delay the onset of full diabetes if you have glucose intolerance. So we try to pick that one. for people with Marfan syndrome, there's some thought that the side effect, that one of the genes that makes fibrillin, one of the products is actually supplied by irbesartan or losartan. And we try to pick those and to put those on board. The beta blockers can have more side effects, but they decrease wall stress.
Okay.
They also help with palpitations or arrhythmia, which can go hand in hand with aortic disease.
Mm-hmm.
So we may try to pick a particular medicine for a particular person also because it has a good side effect.
Mm-hmm.
So with all the different classes, we try to pick the ones that help your disease the most, and secondly, help the other things that are going on. Some people have headaches. A couple of them are headache medications.
Okay, very interesting. All right, let's get back to this questions here. All right, Carrie, I was diagnosed with, oh wait, let me go to Jean real quick. This is whose mother and father had passed away.
Okay.
She said she has a tooth from her mom. Could this tooth be used in genetic testing? No syndromes, and they are being screened.
So I don't know if they can from a tooth. We can find out about that. I can actually let you know if you can get back to her.
I'll get back to you. So
okay, but the tooth is dentin, which I'm not sure how much live DNA would be there later.
Okay.
If it hasn't been connected for a while, it's the actual like cells or tissues that we can get the DNA from. Okay. Hair, they can definitely do.
Okay. All right. That's good to know. Carrie says she was diagnosed with ascending aortic aneurysm at age 54. Her dad died at 54, and her paternal grandfather in his early 60s. Not positive for those causes of death, but knows it was heart-related. No dissection for her, and she is being monitored by a doctor. The question is, should she and her children have genetic testing? She was diagnosed, she has an aneurysm. But no dissection.
She does have an aneurysm.
She has an aneurysm.
She should absolutely do the genetic testing. And the genetic testing she should do, Carrie, unless you have any features of Marfan's or Ehlers-Danlos, you would have to have the geneticist actually look and see what specific testing you could do. Or if you really don't have any of the features, there's a thoracic aortic aneurysm and dissection profile commercially available through all of the gene companies. There's a little bit of difference in the profiles in each company, and that's why you really want to have somebody look at you, look at your insurance, and figure out what is going to be the best profile. But if you have an aneurysm and you have that family history, it'd really be worthwhile, and there's probably at least a 60 to 80% chance you'd be able to find out the exact cause and test your family members for the spot on the gene that puts you at risk and know whether or not they're at risk.
Now, before we go to the next question, where can she start to figure out who to go to that would be a geneticist? Do you ask your cardiologist?
So either the cardiologist or if some cardiologists will do it directly. Mm-hmm. If your cardiologist does not do the gene testing directly, they can send you to a geneticist.
Okay.
Family practitioner or primary care could also send you to a geneticist.
Okay, good to know. Mm-hmm. All right, Bobby is a 17-year survivor. Should I still be getting an echo every year, or can I have it every few years?
Depends on your specifics. And again, if 17 years is a good way out, you're completely stable. It depends, are they following still an aneurysm, or is it completely replaced and repaired? Did you have any heart side effects? Do you have a prosthetic valve? So there are little variables. There are a lot of little variables, and there's not sort of a number of 10 years out you get to go every so often. Mm-hmm. But if really your heart looks perfect and you have a replaced root, for example, then certainly you could go every few years.
Okay. Hi, Jamie. T again. I have a personal question. I have an aortic dissection and she had a stroke. She's wondering if she can still, I get a lot of people ask this, she wants to know ride on rides, like in an amusement park. She wants to ride a roller coaster. She's also wondering if she can still scuba dive in the future, and that's really interesting too. I've had people talk about that. Mm-hmm. I know that snorkeling is definitely okay, but I was a huge roller coaster aficionado, and I feel as though if I got on a roller coaster now and hit that G-force, which used to caused me such pressure, I would just probably implode if I went on one now. So what would be your answer
there's
to roller
not
coasters?
any true studies, but really I would avoid roller coasters.
Yeah.
Again, real easy ones, fine, especially if you don't get worked up. But if you get really excited and worked up, you're going to skyrocket your blood pressure. Okay. And also, again, the acceleration, deceleration is a force on the aorta.
And what about scuba diving? Scuba
diving, the same thing. You're going to have high pressure. So really up to about 20 feet, you're fine. So if you want to scuba in the lower levels, or snuba, that's the new thing.
Snuba, yeah.
Yeah. So snuba or scuba to say 20 feet is going to be fine, but I wouldn't do the 40 to 60 feet because the pressure is really high.
Okay. All right. Just seeing if we have any other questions. I think I've hit all of the questions. And of course, I just had a question, and because, you all can appreciate it, just left my head that fast, actually. It just went out. All right, well, we're just going to give it another minute in case anybody else has. I'm seeing hearts fly across the screen, which is great. What was I going to ask? Okay, so I'll just ask a question because it has to do with myself and because I can control over this. Aortic valve, I have my own valve, but now there's insufficiency. So people that were able to have their own valve spared, is this something that we need to worry about eventually just failing? What's the likelihood? I mean, because as it is, as a dissection survivor, we see that terrible bell curve that 5-10 years out, well, at least the first 5 years, the mortality rate increased, which was, strange. We realized that it's probably for those individuals that have other health concerns, are older, are overweight, are smoking. So we try not to pay attention to those mortality rates as they go up the longer you're into surviving. But what do we need to worry about as far as our valves if we have our own and if they're starting to go bad?
So for people that were able to keep their own valve, generally if the root is really reinforced and it's not continuing to enlarge, the problem often wasn't of itself. It was that the roots stretched and the leaflets couldn't actually touch each other. Okay. So there was a gap. And then the question is how well that gap came together. So depending on how much leak is actually there, some people actually it's perfectly repaired and they have a perfectly functioning valve. Some people have just a little bit of leak that doesn't really bother them ever. And it can be any gradation of that. So you would go back to following that valve the way you'd follow anybody with a leaky valve. Okay. But again, it's usually a better prognosis because the valve itself isn't usually abnormal. Okay. And this is taking out the people that have 2 leaflet valves. So again, you have a mixed group of diseases here. Right. So if you have a 2 leaflet valve and aneurysm, that's very different because the valve there is the primary problem. If you have a 3 leaflet valve, which is the normal valve, and you had an aneurysm that made your valve leak and had that repaired, then it depends on the repair and the size of the aorta at the repair and whether it continues to dilate or whether it's holding. Okay. So often that is never a problem. Okay. Good. Just made you put my mind at ease tonight. That's great.
Couple other questions. So we talked about blood pressure, and you had said that if it goes the bottom number and it's above 100, or the top number hitting 200, and about a half hour you've taken meds, you're drinking lots of water, you're relaxing, you're meditating, and numbers aren't going down, to go to the ER. Other people tend to feel different pings and pangs. A lot of times it can be even a similar situation to dissecting, and now if you've gotten a graft, your graft isn't dissecting, so it's mind over matter. But what other sorts of pains or discomforts, at what point do you say it's time to go, or at what point do you how do you turn the brain off from thinking, is this just a muscle pain, do I go? Or do you, if you have a pain, maybe check your blood pressure. If that's normal, then you can say, okay, well, the more emergent thing is out. When do you know that it's really an emergency? Because our bodies do not feel the same way that they used to.
Right, and probably never will, because it's a huge surgery, it's a huge trauma that the body goes through. I mean, some people are remarkable and don't feel anything a month later, but most people do get pings and pangs from the scar tissue. So you kind of get used to which pings and pangs are yours. If you have something, I try to give people things that they can ignore. to start with so that you can at least put those off the table. The things that last less than a minute or that happen in different parts of the chest that are like a lightning bolt or a fleeting, those happen to everybody, and probably those that have had open heart surgery a little more often. That can be from anything from secretions in the airways to acid to muscle spasms in the esophagus to extra heartbeat that anybody would have but you might recognize, and may just be heightened sensitivity.
Okay.
So those are actually pretty normal things. If it lasts less than a minute, happens in different parts of the chest, or is reproducible in positions, those are things you can actually ignore as not heart.
Okay.
Okay. The aortic pain often is a pressure and penetrating pain. It can go straight through to the back or shoulder blade, but it's described often as a harsh or tearing pain. It's always in a stable location, and it's persistent despite whatever position you're in.
Okay.
If you're getting that type of pain anywhere along the torso, that's something that should take you into the hospital. And do not leave without at least some sort of scan, EE or a CT or MR scan.
Okay.
Because there isn't anybody who can just look at you or touch your arm and say, hey, you're okay. You really do need that objective assessment.
So you really wouldn't want to advocate for yourself if you're not going to a typical hospital that people tend to know you when you walk in. And
Right.
If I walk into mine, they just pull my name up and they know right away that that's where I had my dissection, and they know they always give me a scan.
But you're in Florida.
Right. If I'm in Florida, they're going to look at me and say, look at you, don't.
And say, look, you're beautiful, you're healthy, this is,
you pulled your back. And
right,
you have to actually fight and say, listen, I had a dissection, this needs to take place as you're, and this is really good because we never talked about this before. So something that's persistent in the torso area that regardless if you shift, if you try to burp, if you, whatever you do, if it doesn't go away, that's when you should go to the hospital.
Right.
And I know coming out of my surgery, I suffered terribly from a lot of gas post-op. And when it would hit, jarring, and before this wouldn't have jarred me at all. It was just gas, but it was so painful. And I still get it every now and then. And I stop for a second, I do a quick systems check internally, and then I start moving. And if I can get something to move, I'm like, okay, well, now it's going to be all right. Painful, but
well, and there is
right.
also a lot of stomach acid related to the stress and the trauma.
Yeah.
We always put people, or most places always put people in at least 30 days of a stomach acid blocker, a good one.
Yeah.
Like a proton pump inhibitor. And you can take that longer. You should, again, if you get discomfort, it's fine to actually take Tylenol, to take some Maalox Plus, to use Vicks Vapor Rub. Try to get rid of it. If you can get rid of it in 5 or 10 minutes, then it's something you should discuss with your doctor. But if you really can't get rid of it, then you go in.
And you go in.
And again, those things aren't going to fix an aortic problem.
Right, exactly.
And if you do check your blood pressure, if it's way outside of your normal, first of all, think, am I panicking? If you're panicking, try to do the things to calm yourself down. Deep breaths, meditation, a quiet place, lots of water, but try to do things to bring your blood pressure down. If you're not panicking and your blood pressure is way out of range and you're having chest discomfort, it's a 911 call.
Okay.
Right?
We have another couple questions, and then I'm going to ask one more question that I'm sure, well, nobody's asked, but I know it's on other people's minds. So Shirley, who I think, right, it's the same Shirley from our first question. I'm scrolling up here real quick. Yes, so Shirley, who dissected because of giant cell, I can't pronounce that.
Temporal arteritis.
Right. She says, what about her graft? Are there any studies on how long a graft lasts? Well, that would be very applicable to all of us here. How long do these grafts typically last?
Yeah, so hopefully the graft will last indefinitely.
Okay.
Very rarely people have narrowing or tissue that grows where the anastomoses are. If that were to happen, that can be treated through the catheter, and that's more rare.
Okay.
But the grafts should be an indefinite problem.
Great.
Or an indefinite part of you.
Right.
And normal cells will eventually grow over the graft so that you get a nice healthy lining after really about the first year.
Oh, I didn't think
so you get a lot of protection after that.
Okay, that's great. Gail says her son just passed away in August due to a dissection. Should her other two sons have genetic testing, and I'm wondering if Gail should also.
Yeah, so genetic testing is only going to help if you have it on the son that passed, or any other family member with dissection or aneurysm. Okay. Otherwise, it would be screening, again, an echo, CT, MRI, depending on the part of him, if they know it, that dissected.
Okay.
So, and again, Gail needs to be screened, as well as Gail's parents if they're living.
Okay. So if so as you said, the genetic testing would have been done on her son, but now if you know the area where he dissected, you can then try to do genetic testing and pinpoint that. But before, no, you would just do an echo or another type of or CT scan.
Right.
But not only on her other children, but on herself and if her parents are alive.
Right. And if he had any children, I don't know how old her son was, but if he had children, you would want to screen them too. So first-degree family members of the person that died should get screening. Mm-hmm. The genetics really currently only help if you have some either features of disease. And again, in that family, you want to look, does anyone have features of Marfan's? Mm-hmm. Was he a foot taller than everybody else in the family? Did he have, a whole bunch of teeth removed, like, 10 teeth when he was young? Did he have real crowding? Did he have a cleft palate? Did he have any learning disabilities? Are there other things he had that might help pinpoint what was going on? Was he hypermobile? Did he have a lot of joint pain?
Okay.
So those are things that could help to try to protect her other family, because the one gift you can take from his death is to try to protect everybody else.
Mm-hmm. Mm-hmm. Carrie's asking, will her insurance company help regarding recommendations for genetic testing? And I think really you would go to your doctor.
No, your doctor.
Your doctor should be able to help you with that.
Yeah, I think the insurance, I don't know that they would help with that or avoid that.
They're probably going to avoid it altogether. But you can also go to like John Ritter Foundation for some recommendations for genetic testing. Gen X is another one. Is that how they're pronounced? What is their name?
I wouldn't do that. I would go to,
your doctor,
the genetics MD, talk to your primary care doctor.
Okay.
Talk to the pediatrician. Usually the university centers are going to be where you're going to find, for example, a cardiogenetics program is pretty hard to find. We're very fortunate to have one, but it's pretty hard to find. So that's certainly available, and genetics MDs are available in most regions.
Okay. So another question, which is probably on new survivor or patients and caregivers' minds, would be sex. After having a dissection, once you've been cleared, do you check your blood pressure before? Do you stop in the middle and check? Should you be well hydrated before, during? I mean, it's definitely on people's minds, and I think they become very apprehensive and they're scared that this is going to do damage, especially now you feel your heart pound in a very different way. So what are thoughts on that?
When people are cleared to do moderate level exercise, when they're starting their rehab programs, for example, when you get to what we call 4 metabolic equivalents of exercise, that's where you're really cleared to safely proceed with sex. And we want everybody back to all of the natural and wonderful things that they have in their lives.
Okay.
So for things like going for a nice walk, we don't want you shouldn't have to go out up to extremes to do that, right? And it should be the same way for sex. So as you're able to exercise, as you're able to sweep the floor in your kitchen, as you're able to vacuum your house, that would be about the level you need to be comfortable with. See if you're comfortable with those things. And as you're comfortable with those things, you're going to be okay with sex.
So people don't need to be concerned that they're going to blow their aorta or have too much high blood pressure with an orgasm or anything like that.
Right. So again, sex is really a natural part of who we are. And you should have very normal tolerance. Just like, about, again, the level of walking up a flight of steps or vacuuming your house, going for a brisk walk. If you're fine at that level, you're fine to have sex.
Okay. Great. We have another question, and I think we're going to probably have to step off. Well, if you have any questions, now's the time to put them up here because we have about 5 more minutes max. So Gail has asked, again with her son, he was 46 and he was born with club feet and had 2 teeth removed for crowding and had a hairy, I guess, knee, like the, on his neck.
So the clubbed feet and teeth certainly could go with a couple of the syndromes, either Marfan's for sure, or Loeys-Dietz, or even some of the types of Ehlers-Danlos. So there's some things called hindfoot deformities, etc. And that would be the perfect time to actually take some pictures and of her son and go with her other sons to a geneticist and sit down and go through the exact features.
Okay.
And then you could do focal testing. And again, what they'll do is they'll look for similar features, maybe more mild, maybe not completely expressed in other family members. And if there is somebody with some of the features, maybe there's someone else with a club foot or a more minor deformity of the foot, and you would actually be able to make a case to do the genetic testing on that person.
Okay.
And if you find what you're looking for, then you know what to test for the family for.
Okay.
And if not, they will still give screening recommendations for when should you have your aorta checked, what part of the aorta should be checked. And again, if they decide this is something like Marfan syndrome, we would also do imaging.
Okay.
So it's really important to do that. And again, taking pictures of your son that passed may help protect your other children.
All right. If anybody, I feel like an auctioneer. This is it, the final countdown. If you have any questions, if we're unable to get to your questions, please feel free as you review this video and have a chance to take a look at it. Add your questions, shoot us a message at Aortic Hope, and I will be more than happy to forward the message on to Dr. Fisher, and we will get those questions answered for you. And there was the one question earlier.
About the tooth.
About the tooth.
Yeah,
We're
so
going to get the tooth.
I think that the answer is no, but I will get the answer for sure.
And I will post it here as a comment just regarding the tooth and DNA. I will post it because she's going to remind me when she tells me the answer because I already had forgotten the question.
Right, and what I'm going to do is I'm going to email 2 of the genetics companies tonight and see what they could do.
Okay, great. Thank you all for watching, and we do thank Dr. Fisher. We gave her a stress ball and our keychain to light the way. How am I turning it on? Here it is. So she's gotten these as a thank you from us. We always appreciate you being able to do this, and it does mean a lot to everybody. Again,
well, thank you. I will de-stress with Aortic Hope, and
good.
I wish you all a happy holiday.
Thank you. Have a great holiday, guys. Talk to you soon. Bye-bye.